Hello, everyone, and welcome to the webinar, Tools to Support Effective Collaboration for Strengthening Families. I will now turn it over to our moderator today, Candace Ward, the Program Area Manager for Prevention and Child Protection at the Center for States.
Great. Thank you so much, Chris. Good afternoon, everyone. We are so grateful that you can join us today, and we're so happy to be able to share information with you about approaches and tools to help support effective collaboration for strengthening families. First, I'd like to introduce our speakers for the day. Can we have the next slide, please? First, I'd like to introduce Ms. Laura Radell of the U.S. Department of Health and Human Services. We also have Sheila Pyries of the Human Service Collaborative, Catherine Root of the Nevada Department of Health and Human Services, Doug Swisher of the Center for Families, Peter Pecora of Casey Family Programs and the University of Washington, and Paul DiLorenzo, Center for States Consultant with our National Authority Prevention Team. Next slide, please, for our agenda. So we are looking forward to a wonderful session today, and we'll be sharing a whole host of information.
The first agenda item is to review the session objectives. Next, presenters will discuss the importance of building effective and trusting partnerships.
Specifically, we'll be talking about the ASPE Toolkit, which will help in supporting effective collaborations, learning more about its utility in the Title 40 Prevention Program Plan Development for Family First. We'll hear examples from the field that help to illustrate and highlight the unique approaches and strategies used in partnering with sister agencies and private and community-based providers. We'll hear examples of what funding solutions look like in these collaborations, as well as the role of data collection, CQI, and evaluation in our collaborative efforts. We'll also hear about lessons learned as folks have embarked on their journey towards operationalizing collaborative systems of care. And then we'll engage in a panel discussion. So let's talk a little bit about our objectives for the day. During the course of the session, we want to help you recognize and understand the challenges that may be inherent in partnerships and collaborations by sharing examples from our speakers on strategies that they've employed and you can consider to help mitigate these challenges as well as lessons learned. And we'll want to share information to help you learn about the utility of the ASPE Toolkit and help you to understand the importance of and increase your knowledge around the strategies for CQI evaluation and funding approaches. So I wanted to sort of shift for a second and sort of set the stage and share a little bit of context. The tools that we'll be sharing today should serve as a guide and support to help you operationalize your efforts as you capitalize on opportunities for family first and move towards creating prevention-focused systems. It's important to recognize that the tools are just one component and do not replace the importance of relationship building, listening to our partners, and building on successful efforts that may already have been able to address some of the issues that we're aiming to impact. Use of these tools and approaches have to be built on the foundation of good relationships and understanding the uniqueness of the needs of your communities and jurisdictions. There's no set playbook that we can all use to do this work, and it's very much an iterative process. So we'll be figuring out solutions as we move forward. It's also critical to recognize that using a guide or framework to operationalize more holistic and supportive systems that strengthen families must also involve those families in building the system that works for them. It's easy for us to get into the nuts and bolts of the work and at the end of the day, lose sight that this is about improving outcomes for children, youth, and families. It's important for us in our work with partners and communities to lead with shared values on families that we can all center ourselves around and stay grounded in. If we can operate out of those shared values and collaboration, we know that our partnerships will be stronger. We see successful collaborations as the ones where folks have been able to figure out how to change the rules, adapt and pivot effectively. Those that partner not just with sister agencies, but also with community and private partners. Those are critical to successful outcomes. And those that lead with meaningful engagement and integration of youth and families that they serve in their planning, policy development, and implementation of all change efforts. Next slide, please. So before we begin our session, we wanted to kick off and hear a little bit from you guys, our participants. So if we can please bring up the poll. Okay. So we want to hear from you about what are the most challenging barriers that you find in building effective collaboration. So please note that you guys can choose multiple options. These include, struggling with building strong relationships, divergent or conflicting policies amongst partners, divergent or conflicting practices, or a lack of knowledge or understanding of our partner's priorities. Figuring out how to use resources in collaboration, as well as getting to a common language or shared understanding, as well as a shared understanding of data and data collection methods. So I'll take a minute or two and just let you guys go ahead and make your selection. All right, just taking a second here to get these results tallied up. All right, so it looks like we have about a third or so of folks who've identified struggling with building those strong relationships. Another third or so really around those policy issues, right? How we, the difficulties in sort of navigating through the various policies. The other third or so around practice issues, definitely. Recognizing that as we, attempt to partner together, that we all have our different sort of rule books that we utilize in order to deliver our services. So definitely see the challenge there in being able to sort of reconcile that as we attempt to work together. Absolutely.
Other polling results are 36% chose lack of knowledge of partner priorities. 34% chose figuring out how using resources in collaboration. 33% chose getting to a common language or shared understanding. And 32% chose shared understanding of data and data collection methods.
So what we do know is that this is hard work, right? And we recognize that we can't go at it alone. As we can see, there's so many different contextual factors that need to be navigated. Sometimes there's even some historical context that can impact our ability to collaborate effectively, right? Sometimes we inherit certain relationships that can be challenging for new leaders or for folks as we go into communities and attempt to initiate relationship building for the first time. Also challenging to work through those myths about what we can and cannot change in terms of policies and practices. So yes, definitely something that we've seen in the field a lot. But one of the things I definitely want to put out for you guys is that we are not alone, and you're not alone, in trying to navigate these complex issues and barriers to effective collaboration. So with that said, we're happy to bring our wonderful speakers to you today to share their experiences with these tools, strategies, and approaches that can be employed to help mitigate and address some of these challenges that you've all described in working to build effective relationships. So now I'd like to turn it over to our first speaker, Laura, to talk a little bit about the ASPE Toolkit.
Thank you, Candace, and good afternoon or good morning to all of you, depending on where you are. I'm Laura Radel, and I work for the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. We're generally referred to as ASPE. We are part of the Office of the Secretary of HHS, and ASPE serves as an in-house think tank using research and policy analysis to consider ways of improving HHS programs. I work in ASPE's Division of Children and Youth Policy, and for over 30 years have focused on the well-being of families involved with the child welfare system. My role in today's webinar is to introduce you to a new resource for states and their partners that we're calling Planning for Title IV Prevention Services, a Toolkit for States. It is made up of a series of resources on different parts of the process of developing a Title IV Prevention Services plan. Each part brings together information and links to useful websites and materials for those seeking to plan for the implementation of the Title IV Prevention Services program. The consulting firm Mathematica developed the toolkit under contract to ASPE. Next slide, please. Our intent with the toolkit is to provide the best available information so that states may gather input and data they need to make informed decisions that best meet their needs and that lead to a strong prevention services plan. The toolkit is composed of 5 guides mapping to different tasks involved in developing a strong prevention services plan. I'll describe each of these in a moment.
The toolkit's goals are to help states strategize for implementation, identify decision points and considerations, leveraging existing resources, and access examples and resources.
Our materials focus especially on issues where the Title IV Prevention Services Program may interact with services funded by other federal agencies, including the Center for Medicare and Medicaid Services, or CMS, which operates the Medicaid program, the Substance Abuse and Mental Health Services Administration, SAMHSA, which funds programs providing behavioral health services, and the Health Resources and Services Administration, or HRSA, which runs the federal home visiting program known as McV. We also consulted with child welfare agency staff in several states and child welfare stakeholder groups, and each of our federal partners agencies reviewed drafts of the materials to make sure that they agreed with the information we were providing about their programs. Next slide, please. The tool on identifying and engaging partners provides suggestions that may be helpful in developing partnerships to implement prevention services. For example, each state has a women's substance use treatment coordinator who could be a good entree to those parts of the SUD treatment community most likely to be serving child welfare clients. And the McV Home Visiting Program requires a state plan that contains detailed information about existing home visiting efforts in your state and could help you to connect with leaders working in that arena. The toolkit provides information on how to identify those folks in your state, as well as others who may be helpful as you seek to weave together a coherent prevention continuum.
Circle connecting the 5 elements of the Identifying and Engaging Partners tool surround an image of shaking hands. The elements are: leverage existing planning councils, identify efforts in your state sponsored by related federal programs, seek family and participant input, anticipate common challenges in engaging partners, and show examples of possible partnership structures.
Every state is unique, but we provide suggestions on some good places to start and links where you can find information on what these other programs and organizations have going on in your state that you might partner with. Some may be among your existing collaborators, but others may be organizations you haven't worked with before. If the 4E Prevention Services Program is to be a stepping stone to a new way of serving children and families, it will be helpful to partner with agencies and organizations who bring new perspectives that will help you to build credibility and trust with families who may currently fear traditional child welfare services. We also provide links to resources on engaging families, as well as resources on collaborative planning and service delivery. Next slide. The tool on assessing target populations, service needs, and service coverage provides information on things like what data is useful for understanding who is at risk of entering foster care in your state, what evidence-based programs might be relevant to your goals, how to find out details about what SUD and mental health services are covered by Medicaid in your state, and where to find your state's plan for using SAMHSA block grant funds.
This part of the tool also helps assess the service needs of a target population and map the exiting coverage landscape.
I won't spend time on this today since these topics are also covered under other materials available from the Center for the States and the Children's Bureau. Next slide. The tool on determining priorities, goals, and actions is based on interviews with state child welfare leaders and provides links to resources on the implementation and adaptation of evidence-based practices and suggests tools for building logic models that can help program leaders think through which possible interventions best offer opportunities for addressing the challenges they seek to address in the target populations they seek to serve.
This part also suggests how to gather the information that can be used to create the prevention services plan.
Next slide. The toolkit places a significant emphasis on understanding the potential roles of various federal funding sources, as well as decision points around how to grade funding sources to maximize the utility of new 4E prevention monies. In this tool, we catalog many of the relevant federal funding streams that may already be providing services related to the 4E prevention services categories. We suggest key questions to ask about how various services are currently paid for in your state and who might have those answers. And we explain how you might leverage Medicaid, TANF, McV, and other federal funding streams that cover services similar to what's in the prevention program service categories. Overall, we suggest that states think about the service array that they would ideally have in place to address the needs of the target populations they've decided to focus on, what's already covered with the funding streams that are out there, and where the gaps are for families whose children are at risk of entering foster care. For instance, if you're in a state in which postpartum women lose Medicaid coverage 60 days after the birth of a child, you'll likely have a population of women with substance use disorders who have significant child welfare risks, but who you've successfully engaged in SUD treatment. But they'll likely need treatment beyond when their Medicaid coverage ends. That's likely a key point at which there is a risk of treatment dropout, and it's a perfect place where 4E prevention funds could step in as Medicaid withdraws to ensure treatment continuity, decrease risk of relapse, and keep that family stable so that the children don't need foster care. Thinking about the key points at which the families you're targeting come up against service gaps related to the types of activities that the 4E Prevention Services Program may fund is a helpful way of figuring out where your 4E prevention dollars could add the most value in producing better outcomes for the families you serve. Funding more of what some other agency is already providing is one thing, and is potentially useful in reaching more clients. But figuring out how to plug holes where families currently fall out of your service system, and keeping them engaged in order to truly change lives is where you can really make a difference with this funding stream. Our materials will help states identify the various relevant federal funding streams and how to map their existing funding landscape. We provide information on key features of these other federal funding sources to help state leaders think through the advantages and disadvantages of potential funding strategies. And we provide information for each program on things like differential match rates, eligibility criteria, time limits, and other features that are important factors in making optimal funding decisions. Next slide. The final section of the toolkit crosswalks the information from the other parts to the 4E Prevention Plan preprint. In addition, appendices provide supplemental information with a more detailed overview of Medicaid, what comprehensive service arrays look like in SUD and mental health treatment fields, and the required elements of a 4E prevention plan. Next slide. There's a great deal of information in the toolkit. We've tried to make it practical and easy to use. It can be used front to back, or users can jump in at whatever step makes the most sense for where they are in their planning process, or which element of the process they are responsible for. We hope that you will find it useful as your state develops a prevention services plan. This slide includes a link to where you can find the toolkit on our website.
The toolkit is located at https://ASPE aspe.hhs.gov/the Roman numeral 4-E-prevention-toolkit. Laura's contact information is laura.radell@hhs.gov.
In closing, the 4E Prevention Services Program represents an exciting opportunity to serve families differently. States face important choices about whether and how to make use of the new funding stream. And by making strategic choices, states can maximize the value added by the new program. Thank you all for your participation today and for all you do for families and children in your community. I hope these materials prove useful to your efforts. And now I'm going to turn it over to Sheila Pires, who will take over presentation role.
Thank you, Laura, and hello to everyone. I'm with a group called the Human Service Collaborative. We work with states and communities around the country to build more integrated delivery systems for children and families. And we're part of the National TA Network for Children's Behavioral Health, hubbed by the University of Maryland. And we are happy in that role to also have input into and review the toolkit that Laura just talked about. And I also wear another hat as the senior consultant to the Center for Healthcare Strategies, Children in Managed Care and Child Health Quality Programs, which work principally with state Medicaid agencies. As Laura indicated, in the toolkit really covers meeting the objectives of the Family First Prevention Services Act and reform of child welfare in general does really require taking a cross-agency kind of perspective. And sort of the best way of thinking about how to approach other agencies is what are the shared populations of focus that we have. And all of you in child welfare, as a part of Family First, are identifying your priority populations in terms of families that are most at risk for coming to the attention of child welfare, and for those children and youth that are at risk for placement disruption. And there's crossover with other systems in terms of these populations, as you know. So starting with who are the shared populations of focus across systems and what are the shared outcomes we want to achieve is a place to start. And that has you moving then from a mindset of funding programs and providing grants within child welfare to thinking more about collaborative financing to support a strategic cross-agency agenda in order to meet the outcomes of Family First and child welfare reform in general. The next slide, please. In Medicaid, Medicaid can pay for a number of the services on the 4E clearinghouse list. Services like functional family therapy, multisystemic therapy, parent-child interaction therapy, for example. It can also pay for services that are not on the clearinghouse list yet. They may end up being. But, for example, many state Medicaid agencies are paying for mobile response and stabilization services, particularly newer generation models that are geared toward children and youth and their families, and that provide longer-term crisis stabilization with one-on-one crisis stabilizers. That's an extremely important service for families who are at risk for and also involved with child welfare. Also, wraparound intensive care coordination can be another really important support for families at risk for child welfare involvement. So building those relationships with Medicaid really are worth the investment. Public health, and Laura referenced this, particularly maternal and child health divisions within your state public health authorities, are already providing in-home parent skill building programs, including well-supported programs on the clearinghouse list like Nurse-Family Partnership and Parents as Teachers. And it makes much more sense from an efficiency standpoint and from stretching resources to build on the capacity within public health rather than child welfare trying to recreate their own in-home parent skill building programs. The discussion with public health is how can we expand public health capacity to ensure that there is access for families that are involved or at risk for involvement with child welfare. The next slide, please. Similarly, and again, Laura referenced this, and there's more about this in the toolkit, but state substance abuse prevention and treatment authorities, and for those of you that are county structured, there may be also, there are county agencies that you're also looking to build partnerships with. But substance use authorities in states may already be funding substance use residential treatment for mothers and babies. And again, it might make much more sense to expand their capacity and their provider base rather than child welfare trying to build its own. They also may be providing not just residential, but outpatient services, intensive outpatient services, including evidence-based practices for both adult family members and for adolescents. Same thing with state or local mental health authorities. Community mental health providers either are or could be providing mental health evidence-based practices both for adult family members and for youth. Next slide, please. Laura referenced the TANF program, Temporary Assistance for Needy Families. And the first 4 bullets here are part of the mission statement of TANF. And if you look just at the first bullet, you see how in sync TANF programs are in terms of their mission with that in child welfare, assisting needing families so that children can be cared for in their own homes or with relatives.
The other 3 bullet points that reflect TANF's mission are end of the dependence of needy parents by promoting job preparation, work, and marriage, prevent and reduce the incidence of out-of-wedlock pregnancies, and encourage the formation and maintenance of 2-parent families.
And they can be, they have some flexibility and can be an important source of funding, for example, for things like domestic violence intervention programs, like Caring Dads or Fathers for Change. And so it's really worthwhile to also, talk with your TANF programs about creative ways of stretching resources for your populations of focus. Next slide, please. So the cross-agency collaborative financing approach not only pertains to services, but also to training and capacity development. So other systems may already have training in place that you can piggyback on, like, for example, behavioral health agencies may already be doing trauma training that you might want to piggyback on. They may also be involved in evaluations that, again, you could piggyback on for those services that you're including in your prevention services plan that are not well supported and where you have to do an evaluation. Maybe you can make it more affordable, more efficient by piggybacking on an existing evaluation that may be going on in another state agency. And then also same thing with continuous quality improvement, particularly if you are trying to expand the capacity of other agency services. They may be already paying attention to quality indicators, and how can you piggyback on their systems to get the kind of quality information that you need for your families and for purposes of Family First. So I will stop there, and I'm going to turn now to Catherine Ruth from Nevada.
Thank you, Sheila. Next slide, please. I am Catherine Ruth, Deputy Administrator at the Division of Child and Family Services in Nevada. And if you're familiar with Nevada at all, you may know that about 75% of our population is in and around Las Vegas, in that tiny red dot at the bottom of the map.
A map shows the population density of the state of Nevada.
Reno is our second urban city, and the rest of the population is scattered throughout 15 rural and frontier counties. Because of our unique composition, Nevada is one of only 2 hybrid child welfare states, where 2 large urban counties administer their own child welfare services, and our 15 rural counties are administered by the state. I oversee a separate office at the state that serves as oversight for the 3 jurisdictions. I started in my position about 1.5 years ago, at which time Family First planning had been going on for about 6 months. When I came on board, we did a little reboot and we hired a team from the University of Maryland Institute for Innovation and Implementation to provide project management and technical assistance. This included Sheila Pyries, who just spoke. We structured our planning with a placement work group to address the congregate care and QRTP requirements, and a prevention group to work on the rest. Next slide, please. Nevada started by identifying who needed to be at the table during our planning, and we kind of identified 2 broad categories, the first being community stakeholders and the second being sister agencies. Within our community stakeholders, we knew we needed to collaborate with service providers for prevention services and also placement providers to address the restrictions on congregate care and the conversion to QRTPs. To achieve this, we were given permission to use a survey created by Chapin Hall to gather information about what we already had in place relating to Family First. The service provider survey sought information about who was providing evidence-based practices already that might be eligible for 4E and what the capacity was for the expansion to child welfare families. For placement providers, we were looking for information on who would be impacted by the congregate care restrictions and who already had QRTP components in place, and then that might be good candidates to convert to QRTPs. Through this process, we identified that most community concerns were coming from the specialized or treatment foster care providers. So we held a follow-up virtual town hall specifically for these providers to explain the changes coming with Family First and to answer questions about QRTP requirements. We have maintained contact with this group. We provide monthly updates about Family First planning, and we've also requested the group's input on our QRTP policies and about starting our rate setting conversation about the rates that QRTPs will be eligible for. On the sister agency side, we recognize the need to leverage what already existed in the state, including services and funding. This included working with our sister agency, the Division of Public and Behavioral Health, as they house Nevada's home visiting, substance abuse, and some of our children's mental health services. We also collaborated with our welfare division to leverage TANF funding, and we're working within our own division to leverage our mobile crisis and wraparound services. And luckily, we have a great relationship with Medicaid, so we've been able to keep them in the loop as well, and that's a really important partnership to foster during this planning. Next slide, please. So going a little deeper now, you will see what Sheila just described in her slides in actual practice. And Sheila has been really great at helping us build these relationships with our sister agencies. So when we first started planning Family First, one of our first goals was to expand and improve home visiting in the state. And in Nevada, our home visiting programs are in our sister agency, Public and Behavioral Health. So we've had several meetings with them to, basically ask them how we can use Family First as an opportunity to expand or fill in gaps in our current home visiting program. We're still in the planning phase, but we are right now looking at expanding parents as teachers to child welfare families and expanding nurse-family partnership to our pregnant foster youth. Our SAPTA program is very interested in collaborating with us to build up family-based residential treatment programs for substance use disorders. And neither SAPTA nor DCFS has the resources or capacity to achieve this on our own, but we're hopeful that working together, we will be able to. And another example of a sister agency collaboration, we met with our welfare division and discussed TANF priorities. And again, we were looking for ways to leverage services and funding that were already in place. And with TANF, we're really looking at using TANF funding to support domestic violence interventions. Next slide, please. So some takeaways. The first one is that Family First is complicated. Child welfare speaks a different language. Not everybody knows what 4E is. When starting with these collaborations, it's really important to get your elevator pitch down to start conversations. and have lots of backup documents available. In Nevada, we created a one-pager to kind of describe a broad overview of Family First. And I also maintain a good stash of links, that other organizations have provided. So I would typically send all those prior to the meeting, but then be ready to talk about Family First as much as needed for that group. The second, we found a lot of misconceptions around Family First. The biggest being basically people thought we were just getting a bunch of federal money. And we had to educate groups multiple times that this is a shift in federal reimbursement and it requires a state match. This was not just a big bunch of money coming from the federal government. There was also another misconception about congregate care, some believing that it had to be eliminated. So we really had to make sure people understood this is a 14-day, restriction. And another takeaway, just know it's going to take more than one meeting, partially because, as I mentioned before, Family First is complicated and there are misconceptions to address, but also because there's lots of details to consider.
In these meetings, start with education, clear misconceptions, get priorities and needs, and find common ground.
Our approach was really to determine what was already in place, describe what Family First was and what it could make possible, and then to see how we could meet in the middle to leverage each other's resources to expand services as much as possible. So that's my quick overview, and I will now turn things over to Candace.
Great. Thank you so much, Catherine. Really great to hear from Laura, Sheila, and Catherine. And, we've had an opportunity thus far to learn about a number of strategies, including cross-systems collaboration, building on existing elements, such as programs, funding, evaluation, and data. And I think that those are definitely some key areas in terms of not reinventing the wheel, if you will, but really building off of what may already exist. I also heard the importance of doing some cross-education about policies and practices, and ensuring that you guys have a cadence of communication across multiple agencies, right? So I also heard about, being able to meet monthly and how that can also support your relationship building. As well as the identification of shared priority areas, specifically shared populations, when you think about and look at the different agencies and who your priority populations may be that folks have been serving. So before we move on ahead and hear from our other speakers, I wanted to take another moment to engage our participants in another poll. We'd like to hear from you guys in terms of the experience that you may have in the following areas in your collaborative efforts. So please share with us if you've worked on interdepartmental project planning, financial modeling, evaluation of collaborative efforts, development of shared metrics, analysis of shared data, or perhaps you haven't had an opportunity to engage in any of these. So please take a moment to respond, and you can select multiple options. All right, let's go ahead and see what our results are. Great. So it looks like a lot of our folks participating today have had experience, almost half, in being involved in interdepartmental project planning, being involved in collaborative efforts. About a third or so have worked with developing metrics and analyzing shared data. Excellent. Not too many folks involved or have that detailed experience in the financial modeling piece. And for some of our folks, about 33% have not touched or have extensive experience in these areas. And this is pretty indicative of the field in general. We know that the financial modeling is often an area that can seem very daunting, and it's a little hard to tackle, the various funding streams that are available, especially across sister agencies, and to do so in a way that is beneficial and meets the needs of kids and families, as well as meets reporting needs and meets the priorities and needs of the agencies. And so I'm happy that we'll be moving into some additional conversation and discussions about funding, as well as evaluation, CQI, and data. And so I'd like to turn it over to Doug now to talk more about the continuum model in Tennessee.
Strategies for funding community-based solutions.
Hello, everybody. Doug Swisher. I'm the Director of Human Services Financing for the Center of the Support of Families, and we provide technical assistance to states and county governments to help improve their systems. Prior to that, I have over 30 years of child welfare financing experience, and the last 8 plus years was spent as the Assistant Commissioner of Finance and Budget for the Tennessee Department of Children's Services. So today I'm going to go over just sort of tell you one of the stories from Tennessee and tell you how we got to where we got to, and then sort of the evolution of the continuum model that's used in Tennessee, and then how that also later evolved into the adding on some performance-based contracting to that model. So there are 2 factors that moved Tennessee into the continuum model. Sorry, next slide. So, one, Tennessee was having some financial difficulties, and it really couldn't sustain the current in-home model that it had. It had different rates for providers that were providing basically the same services, and kids were languishing in congregate care settings. And then another factor that added to that, Tennessee was the beginning of a class action lawsuit where one of the requirements to get out of that was they had to address the issue of getting kids out of congregate care facilities. So Tennessee sat down with its providers, and the provider community was really important in the success of implementing the continuum model, and then also implementing the performance-based contracting model. They were at the table all along through this process. So again, I'm going to talk about some of the planning strategies around the continuum model, the rationale for the continuum model, and then some of the planning, and then later delve into some of the why Tennessee we evolved into the performance-based contracting model that was on top of the continuum model, and that dealt with some of the unintended consequences of the continuum model, and then also what the continuum model builds onto it. I mean, the performance-based contracting builds onto that is the future incentives that needed to be addressed, and then developed agreed upon outcomes, and financial incentives were installed into that. Next slide, please. Okay. The continuum model, the funding strategies were called for a revision to both the cost allocation plan and as well as a new time and cost study process in Tennessee. Again, the budget at the time couldn't sustain the ongoing and rising costs of the number of youth placed in residential care. It just was not sustainable. Okay, so planning called. I mean, we got together with the private provider network and sat down at the table and worked on trying to come up with a solution to that issue. And so we developed the continuum model in Tennessee, where there is financial incentives built into the model where it incentivizes providers to get children into the least restrictive environment as quickly as possible. So the model is designed where provider is paid the same rate for no matter where the child is in their continuum of care, whether he's in their residential placement, foster home placement, or in-home, okay? And so the pricing model for that and the pricing structure for that, the model is, well, the provider does not make money and actually loses money when he's in when a child is in the residential, in a congregate care setting in their continuum, okay? They recoup money and start to make some of that money back if he's in a family-based setting, okay? Because it's covering more than their cost. And then, obviously, when he's in-home, they're recouping more of their money.
The goal of the continuum model is to provide incentive for moving youth through the system.
Okay. So, next slide, please. Okay. So, but what happened under that model, whatever, is that though the model works to incentivize providers to get the children to the least restrictive environment on foster care, what was happening was lengths of stay were still staying the same, okay? Kids were getting to that least restrictive environment, but they were still languishing in care, okay?
The unchanged time in care was an unintended consequence of the continuum model, despite the short stays in residential care.
And so, with pressures from everything from the lawsuit that Tennessee had to wanting to improve outcomes for kids, we developed the continuum model. Okay, and there basically were three things in the developing of the continuum model that Tennessee were sort of like lack of better words, were non-negotiable. Okay. And so that was, we were going to incentivize a reduction in care days. We wanted to reduce reentries, and we wanted to increase permanency. And permanency was defined in Tennessee as reunification or exit to adoption or subsidized permanent guardianship. Those were that's considered permanency in Tennessee. And so the model, everything else about the model was negotiable with the providers, how we got to those things. But again, the three things that were not negotiable were the three, we were going to incentivize, and reward providers if they improved those three outcomes. And so financial incentives and rewards. So there were incentives that were built in whatever, so that if their performance improved, they were incentivized, okay? And if their performance got worse in those three outcomes, there were penalties in that. So one of the things that we did in the model, whatever, to implement the model was providers were concerned about penalties as they developed and entered into the performance-based contracting.
Performance-based contracting includes financial incentives, including fiscal rewards and penalties tied to outcomes.
We held them harmless the first year of implementation that they were in. The other thing that Tennessee did was we phased in this approach, and so you got sort of, like a better word, we had some guinea pigs at the beginning of the thing and had them be successful within the model. And one of the things that it also did is it right-sized the network. The network. We had Tennessee overall went from 100 out-of-home providers to 30. And so providers, partnered together, or they just changed their business model. Next slide, please. Okay. Some of the lessons learned. You can use these sort of strategies, et cetera, in any type of child welfare change effort. It wouldn't have. It doesn't have to necessarily be what Tennessee did around their out-of-home care. Okay, but one of the things that you do want to do in regards to this is determine what your key outcomes are going to be early on. Okay, and then get early input and buy-in from your external stakeholders. Okay, and then again consider what, if any, are non-negotiables, and then everything else beyond those non-negotiables needs to be on the table. You have to have flexibility in any model that you're building or whatever to change the system, and then consider all the input from everybody in regard other than those outside non-negotiables. Okay, and one of the lessons learned in Tennessee was got some early pushback from legislators around, because they're concerned with their providers, but it became a real easy sell to legislators when you sat down with them. And so that's really, in any change or whatever, it's important that you engage your legislative bodies early on around any changes or whatever, and explain to them, because it was really easy to them to say in the performance-based contracting, well, there was no penalty for the provider if they just maintained the status quo, but there were rewards for improvement. And then it's hard to say, well, the legislature said, so you don't want to improve the system? and so again, it became a real easy sell after that. Again. So I'm going to go ahead and turn it over to Peter Picola to go next.
Using data and continuous quality improvement in collaboration efforts.
Thank you. Appreciate that and the opportunity to be here today with everybody. Within the context, we can move to the next slide there on using data and CQI. And so within the context of Family First, states are carefully considering what mix of outcome evaluation and CQI processes should be put in place for each of the interventions that are chosen. So for example, evidence-building outcome evaluations require a specialized design and a data analysis plan. And some examples of that, the factors to consider with that are, comparison group design, how do you set those up? Baseline equivalence between the comparison and the treatment groups, minimizing participant attrition for the folks who are participating in those studies, and having at least a 6-month follow-up after the intervention has ended, which is what the clearinghouse requires as a minimum follow-up period. Not when the intervention starts, but when the intervention ends. Ideally, it ought to be 12 months. But at least for the supported level, it has to be at 6 months. So states like Utah, Maryland, and others are applying for an exemption to not include evidence-building outcome evaluations for the evidence-based practices rated as well-supported that they've included in their plans. And that's to save time and money. Those resources then, if they're not doing the more evidence-based outcome building evaluations for the well-supported evidence, EBPs, they can devote that time and resource into evaluating the promising and supported EBPs. So that's a very strategic decision that a number of states are making right at this moment, or have made as part of their prevention plan. The CQI and evaluation processes should help build quality, fidelity, and outcome data as part of everybody's business operations, everyday business operations, to help build evidence and knowledge about what's working best for whom. Let's go to the next slide. So what can help ensure a successful CQI process? Stakeholder involvement in selecting the assessment measures, the fidelity measures, and the outcome indicators is essential. We want to especially include youth, parents, and line staff who may be completing the assessment measures. Their opinion matters because they're the folks who have to understand the measures and to complete them. So good measures need to inform your safety and your risk assessment processes, as well as in the Family First context, that data is used to inform child-specific prevention case plans. That's what are required by the law. So some of the measures should be clinically sensitive, able to detect meaningful changes in child, parent, and family functioning. That's the bottom line use for a lot of these, right? Not only initial assessment, but is the child or the family or the parent making progress? For example, California, Florida, Montana, and other states have had special planning efforts within their state just focused on selecting the right assessment measures. And states are beginning to outline timetables in their prevention plans for when certain assessments and case plans need to be completed by. If you want a good example of that, go to the Maryland State Plan, pages 16 to 18. You'll see a great example of how Maryland has outlined that in their plan. The assessment measures should be able to be learned in a reasonable period of time, and they've got to have high consistency across the staff who might be assessing the same person. And that's what we refer to in the research world as inter-rater reliability. Let's move to the final slide. So finally, how can you help ensure that the data collected is actually used to inform policy, program design, and practice? Some ways to think about to do that is to use trend data. One-time data doesn't tell you much. You need trend data over a number of years or months to really pick up patterns. And then you want to analyze that data for your Family First work by race, ethnicity, gender, income, neighborhood, work unit, and other factors, right? You've got to be unpacking that data, breaking it down so it really has more meaning and utility for yourself. And then a lot of times, I mean, it's becoming the norm here in the field that we really want to unpack the data with people with lived child welfare experience. So people with lived child welfare experience, line staff, supervisors, and advocates have a point of view and can really add insights about what are the underlying patterns and meanings underneath the data. What compelling stories illustrate key patterns or insights in your data, whether it's your quality data or your fidelity data or your outcome data. We think that circulating the stories is really important because stories and data infographics carry key messages the best. That's what gets retained by people. And finally, as you're looking at your data and you want to make the best use of it, are there any cost or cost savings implications that need to be considered? What comes out of that data that really has an implication from a cost point of view? Thanks for your time today. You now have the pleasure of hearing from Paul DiLorenzo.
Well, thank you, Peter. All these presentations were really fantastic. Glad to be on this webinar today with all of you. Just a little bit about my background. I am a consultant to the Capacity Building Center for States, and I'm also serving as an interim ED for Philadelphia's Child Advocacy Center. But prior to that, I spent 13 years at Casey Family Programs, and then also a good deal of time in both state and local government and nonprofits. Majority of my career has been spent on building these kinds of community collaboratives, and that's given me an opportunity to work both at the state level and in an administrative role, as well as working up close and personal with community and neighborhood groups. And I really tell you the truth, of all of that work that I've done, I find that the work that I've done both in communities and neighborhoods has been the most fun, the most enjoyable, and the place where I learned the most. So what I'm going to share with you today in many ways is really a reflection of what all of those partners over the years have taught me. Let me just say that one of the things that I heard today is very similar to what I've heard in the work that I've done with groups. And that's that starting point, the importance of listening and finding out what are the shared concerns. So let's go to that next slide if we can. And I want to talk just briefly about what are some of the shared concerns that people have. You heard some of this in the presentation. You probably have a similar experience, and if you don't, maybe some of that is a result of maybe just not listening closely enough or encouraging these conversations. Sometimes we can be pretty narrowly focused within our child welfare tunnel and not seeing outside of it. The first shared concern that I think that people seem to have is their desire to want to improve the safety and the well-being of families. And I have to tell you that in just about every successful project I've worked in, and I'm trying to highlight the successful ones here now, they've had a two-generation approach, right? They believe not only in keeping child-focused, but family-focused. And so it's that connection between bridging the need of and the challenge of the family along with the safety and well-being of the child. The importance of working with parents and engaging parents and providing parents with some small wins if need be, or some really major success stories, but whatever they can do to provide a window of hope for people. Another shared concern that these community and neighborhood groups seem to have is that frequently they can look to the poor well-being outcomes for kids and families. But like Peter, I'm a big believer in not having any data without a narrative attached to it, and also not having stories without data. You need both, and the only way you're going to get that is by talking with kids and families in those communities. But I'm going to tell you that shared concern among the groups that we've worked with has been really at the heart of it, that notion about the poor well-being outcomes. And it's not always child welfare that they're going to start with. It could be around poverty, it could be the school outcomes, it could be healthcare disparities. There is another shared concern that we have seen, and that's in the fact that some communities will identify the fact that there are too many children in out-of-home care. And when they begin to see the data of how many children are removed per thousand in their community compared to other places in their city or town or state, it can be pretty alarming, and that will kind of rally them around the importance of strengthening families. Another shared concern is that you're going to get a pretty unanimous agreement that most of the systems that are set up to deal with kids and families are very flawed, and it makes systems improvement very difficult. And we could spend a whole day just on that topic. We know that the child welfare system is a flawed system. We know that our TANF system is. We know that our healthcare system is, right? There's no one perfect system. And so one of the challenges that arises here is trying to find the level of engagement and your level of how far you want to reach to improve and enhance these systemic responses for kids and families. Another shared concern is I think the need to redefine success and to change the narrative, right? We don't want to operate in this kind of narrow environment that we're only interested in how many kids enter foster care or how many abuse and neglect cases, but we really want to broaden the conversation about child and family well-being, which will allow us to think more systemically about primary prevention and even farther upstream family support. But let's not limit ourselves to simply one or two outcomes as a measure of our success. I think the other thing that I found in my work with communities and neighborhoods is that there's a need and a desire on the part of community members and stakeholders to want to be more actively involved in planning and in decision making. And so the work has to be done to develop a more horizontal decision-making process as opposed to the kind of top-down decision-making process that child welfare agencies are typically used to using. And then finally, and I think this gets to some of the points that were raised by our partners earlier on in this presentation, that most of the people that I've worked with will say that there are generational patterns of family instability, poverty, and trauma. Not only child trauma, not only community trauma, but what some people refer to as colonial trauma. And so there really are those three levels of trauma, those generational patterns. And so we're not dealing with kind of the problem of the day. We're really trying to help families and to support families get out of this destructive cycle part of the work that we need to do. So let's go on to the lessons learned slide. Over the years of work that I've been doing and even hearing today, I've come up with a number of things that I think are the kind of common lessons learned among the sites that get started with this work. And some of them are the good news, some of them are not so good news, some of them are just neutral. But I think they're kind of universal to almost all of the projects that I've worked with. And the first lesson learned is the impact of poverty and generational historical trauma on families. It can't be underestimated, the significant impact that poverty has on families, but also both the generational and historical traumas that families have suffered. And I think that results in what we see as disproportionately poor outcomes for certain populations. Another lesson learned has been the value of what I think of as the three most important kind of factors in the work: data, clear purpose, and a dedicated assigned leadership. So we need to have data that tells us a story, and we need to have a story that explains the data. We've already talked about that. We need to have a why of the work, the clear purpose. So many times agencies get started with the question of, why don't we collaborate and do A, B, and C? And there's no real reason for it. There's no destination for the bus, if you will. People have to spend time, be patient, and figure out the why of the work. And getting people to that shared agreement about what are our common desired outcomes can take a while. We don't want to be impatient. We want to listen, and we want to be able to incorporate that into the final decision about what's the destination of this bus. And then finally, on this lesson learned here, this value I raise up pretty high, is this notion of dedicated leadership. So the sites that I've worked with that have been successful, they almost always have an assigned person. It's not something you do in your spare time. It's not a part-time job. It's not something that goes in someone else's portfolio. It has to be an assigned leadership role. And if not, people find themselves becoming overwhelmed and only seeing it as a project or a program and not really an initiative, which it has to be. So another lesson learned is the value of partnerships. I don't think we need to go into that, but the critical role of partnerships and really changing the organizational culture from the single agency that can take on and believes that it can do the job on its own to this notion of shared responsibility. There's also the importance and the value for organic planning, not just tools and checklists. I've used tools and checklists over the years. I've helped develop them. I'm a fan of them in some ways, but on the other hand, I'm a big fan of organic planning. And I think what you have to do is to ask the question, what are the purpose, what's the role for tools, what's the role for assessment instruments? It's to help clear the path. It's help to kind of answer questions or maybe to provide information that other organizations, other initiatives have come on in the past. But it does free the time up for the leadership of these initiatives to be able to create and to deepen their relationships. And so the organic planning, that creation of leadership, the creation of relationships by the leaders should result from using the tools, which helps you save some time. There's a shared value around common value around community involvement. There's also something that you heard today, which came up in the question around your challenge, and that has to do with this notion of a shared customer service model, if you will, right? The practice model, getting everyone to agree on how you're going to approach families. If you think about the best customer service organizations in this country, the businesses, the companies, for example, they're known for their customer service. You probably have maybe a hardware store in your neighborhood or a local business that's really locked into this notion of customer first, right? We know some big companies like Nordstrom are known for these kinds of things. And unfortunately, in human services, we rarely develop a customer service model. If you're going to have a partnership, if you're going to have collaboration, one of the things you have to decide and actually work on and reinforce each day is this notion of the customer service model and the transformed practice model. I think we also saw and have continued to see in other places the value of supports and not just services. So we're not just trying to add more and more supports into a community, more and more more and more services into the community, but we want to create social capital. We want to be the instigator of people getting to work with each other, to help each other, to create those connections, those community connections. Think about one of the most effective community connections and therapeutic interventions that we know, right? 12-step programs. It's not exactly therapy, not exactly support. It's a combination of both. But what it does is it kind of puts on the members of the 12-step group the responsibility to help each other, to help themselves. And I think that's what we want to do within communities, within neighborhoods, to build that community of mutual support. Some days are going to be great, some days not so great. But I need to depend on my community and my neighborhood, not the government agency. And then two more lessons learned that I think I want to highlight. One is that place matters for sure, but don't start with place. Start with the process. So many projects that I've worked on over the years and initiatives start with, within 10 minutes, they're talking about, let's set up a community center in the 19004 zip code, whatever it happens to be, without really thinking about and creating the process that's necessary to get to that point. Place will come with the decision. Form follows function. And so what you want to be able to do is to think about the extent to which the place reflects the process. In work that I did in Gainesville, Florida many years ago, and it continues to thrive there, they spent a lot of time not only thinking about the why of their work, the purpose, but also the process, how important that was to them. They eventually found the place, but it was really after about 9 months of discernment. And that was okay because progress was being made and they were creating that cohesive group with a shared set of outcomes. And then finally, two things that I think are related. The first is it's really hard to decide what not to do. If I sat down with any one of your groups at this moment, we could spend all day with lots of print paper going through all the things you want to do. But if I spent some time with you and asked me, what are we not going to do? What are you not going to do going forward? That really becomes kind of an uncomfortable conversation, right? Because you have to think about what am I going to redeploy? What am I going to do differently? How am I going to spend my money this year? How am I going to deploy staff differently than I did last year? And that becomes uncomfortable, right? Because people are used to doing things a certain way, and making those changes can be painful. None of us like loss. None of us especially like the loss of what we perceive to be initially that loss of control of our service delivery process. And I think that related to that is the second kind of subpoint, which is that the successful projects are always thinking about the future. It's not a finite game. It's not a short-term game. It's really the long game you're making decisions for. And so I'm not just making a decision that's good for today. I'm really thinking about the future. Good leaders are always thinking about what's next. They're always thinking about what's ahead of the curve. I hope that's been helpful for you. I really enjoy hearing the presenters, and now I'm going to turn it back over to campus.
Fantastic. Thanks so much, Doug, Peter, and Paul, for your additions to our session today, specifically around funding and collaboration, data, CQI evaluation, as well as those fundamental and key elements that we need to be keeping at the forefront based on lessons learned in terms of our making sure that our collaborative efforts are successful. So in the remaining time that we have, I'd like to take a couple of minutes to just ask you guys a few questions, and wanted to direct this first question towards Doug, which came out of the participant chat. So Doug, specifically in the Tennessee model, were providers less likely to take on complex cases because of the challenges to meet the outcome? How was acuity or case complexity integrated into the payment scale or the outcome expectations?
Okay, so under performance-based contracting, part of the model, what it does is it statistically works that kids are entered into what we call entry cohorts and they were divided into strata, okay? And those strata, okay, were statistically determined what their experience in care was going to be. And so it didn't matter what level of care you were in, it mattered what strata you were in. Again, as the model evolved, we added some strata on some unique populations, but ultimately, initially it was, the strata. So in other words, the stratas were 0 to 12 and up, and juvenile justice, and then for your in-care and then we had an in-care populations strata that dealt with kids that were in each of those different stratas greater than 2 years or not. And so that experience told you what their experience was going to be in foster care. It didn't matter, if the kid had, statistically more, treatment needs or whatever, and he was like in a level 3 placement, whatever. If he was in a strata, his experience was in foster care was historically had been the same as a kid that was in level 2 with that same age strata. Okay, so it didn't matter. So again, what we were doing was we were paying the provider more to deal with those treatment needs. So that didn't. And then the other thing about the model was, and again, it evolved, but it still is now. We judge the provider based on his historical data and his historic populations. So his mix was a certain mix of kids and certain levels of kids. If they were taking that same level of, kids, and then they would continue to take those kids, and all we were doing was asking them to get better at their performance. So I hope that answered that question. Again, do providers attempt to what you're calling gaming the system? Whatever, they attempted to game the system, but ultimately it wasn't very successful. If they were trying, in the short term they may have been able to game this, but ultimately it didn't. Ultimately, if you're judging yourself, and ultimately the system, the model worked to not allow the gaming the system. So, again, I hope that answered your question.
Yeah, thanks, Doug. And I would say key for me too, and what you shared was also just that, the identification of those non-negotiables and how that helped to build a usable model, as well as, the no penalty for, I think it was the first year, which also helps to ensure that there are those wins, right? Those quick wins or the wins for partners that can help to further create buy-in, right? Recognizing that, that the work is definitely taking on, a different look and definitely being transformed.
Yeah, and just so in context, ultimately the performance-based contracting was phased in over 4 years, and so we had, but ultimately, of the 30 providers that became performance-based contractors, again, there was qualifications and everything. That whole harmless model, aspect of the model, only had to go into account for 2 providers in the first year. So basically 28 out of the 30 improved their performance and got financial rewards in the first year of performance-based contracting. So,
all right, yeah, thanks.
Yeah.
So the second question I'd like to direct towards Catherine, and this is also born out of our participant chat as well. But please share your thoughts on how we might ensure that all the very diverse set of stakeholders in these collaborative efforts, key of these being families as well as informal stakeholders, can feel empowered to be an equal partner in the work of prevention.
Sure, that is a great question. I would say what we've learned is, you know, a great way to approach collaborators is from a perspective of, you know, hey, this is Family First is this new thing, and we have an opportunity to support or expand what you're already doing, you know, or we have a potential to address gaps that you found in your services. And this is really kind of different from going to a sister agency saying, hey, we have this opportunity to draw 4E funds. Here's what I think you should do with your program to support child welfare. And so just the way of approaching the sister agencies has been really helpful. I mean, they are the experts on their program, and they know what's working well, and they know, you know, what counties would really love to have a particular program, but there's unfortunately no funding to get it out there. So what we really place the trust in the folks that were already doing the work to plan with us. In fact, sometimes our meetings just started with an explanation of Family First, and then asking them where they thought they might fit in or how they could leverage Family First, and not the other way around. And we found that sort of led to, you know, sometimes some silence while everyone kind of tried to process what was going on or what the opportunity was, but also to some really positive steps towards collaboration and, you know, leveraging what already exists in the state. So I think the approach is really, really important.
Yeah. Thanks, Catherine. Paul, I'd like to direct one of our last questions to you, which is in terms of, you know, based on your experience, and, you know, you've mentioned, you know, making these decisions for sort of that future, you know, and folks really being in these partnerships for the long haul, right, playing that long game. What would you share with participants around what's needed to help maintain relationships over time?
No, that's a great question. You know, it takes a lot of nurturing. You know, I think I was just talking with somebody about this the other day. Child welfare agencies can't parachute in and out of the community. There needs to be a commitment to it. There needs to be a long-term engagement with the community. Child welfare agencies, public and private, especially the public agencies, need to see themselves as a partner, not necessarily a leader. And there's really a lot to be learned from the servant leadership philosophy as it relates to this. But the nurturing and the creating and the nurturing of relationships is really critical. The other thing is to think about that collaborative as being something more than just a service center for a particular zip code, right? But really part of the ongoing organizational culture change of an agency, that we're not just funding the XYZ program in such and such a community, but our relationship, our partnership with this agency, this community group, this group of stakeholders, for example, is part of who we are as an agency. It's part of who we are as an organization. And so they have to begin to see it as an extension of their organizational culture, not just a vendor-contractor relationship.
Great. Thank you so much. And so we are coming up on time for our panel questions, but I did want to add that any additional questions that we were not able to address that came from our audience today, we'll be working with our speakers to follow up on those questions, and we'll be sure to send out a communication after the session today to ensure that you guys can get your responses. So I'd like to say, you know, many thanks to our speakers for sharing their diverse experiences, the multiple tools, strategies, and approaches that they've employed to support the execution of collaborative efforts among both public and private family and child-serving entities in order to advance a more prevention-focused system. A lot of what you know, you all shared today are really just examples of what we hope folks will be able to take some nuggets from, that they'll be able to walk away with to help support their own collaborative efforts happening in communities and systems. And so if we can move to the next slide, please. So in closing out, wanted to share a couple of reminders with folks. First of all, a reminder that the Capacity Building Center for States is hosting our 2020 Child Welfare Virtual Expo on September 4th, and you're able to register using the link included in the slide deck, and that slide deck is available in the resource pod for download now. This year's topic is on strengthening families through prevention and collaboration, much of what we've been talking about today. And we're excited to feature some really fantastic sessions and encourage you to check us out. Next slide. We also encourage you to stay connected with the center. You can connect with us through our Gov delivery option. The link is on the slide here.
Sign up to receive news and updates from the Center for States at public.gov.delivery.com/accounts/signup/10906.
And you can also connect via Facebook, Twitter, and LinkedIn. I'd also like to alert you to the evaluation survey that is available for this session in the resources pod. We would love to get your feedback and hear what you have to say about your experiences today so that we can continue to improve how we deliver our events to you all. Next slide. And on our very last slide, if you would like to reach out and contact us, there is a widget in the platform at the bottom that looks like an envelope where you can contact us directly or through the email and information provided there on the slide.
Contact the Center for States via the following website, https://capacity.childwelfare.gov/states/ or via email, capacityinfo@icf.com, or phone 844-222-0272.
And so lastly, again, a special thanks to our speakers. You all did a phenomenal job. And many thanks to you guys, our participants, for joining us in today's session. We look forward to connecting with you all again soon. Thank you.